Hey, well, welcome everybody. Thank you so much for coming out to this special co-hosted presentation between Northern Health Research Seminar and the Health Research Institute Seminar. My name is Leanna Garraway. I'm manager of the Health Research Institute. And I just want to take a moment to acknowledge that we are on the traditional and unceded territory of the Lheidli here on the UNBC campus in Prince George. These are the members of the HRI Seminar Series Planning Committee, and added to this, of course, today is Northern Health, Marcelo Bravo in the audience there. We just like to acknowledge that our seminar series has some financial contributions, including from Sun Life Endowment Funds and from the Faculty of Human Health Sciences here on campus. We also just want to take a moment to plug that we have a brand new HRI online database, membership database, which is a fantastic piece that Dr. Bakar Hack and his Berg Lab developed for us. So if anybody would like to become a member of the HRI, just go right on there. We have different membership tiers. We have a student tier, UNBC tier, and a partnership tier. We have a number of upcoming events over the autumn. October 3rd, you can find all of these on our website as well. But Health Research BC is going to be on campus, and that meeting's open to everyone. We have Genome BC coming to meet with everyone. We have Dr. Virginia Braun from New Zealand coming on to campus. We have an education and training day. Registration will be open for that soon. And finally, we have our final seminar series of the autumn before the holiday break. And today I'd like to welcome our visiting scholar from the UK, Dr. Bonnie Teague. So Bonnie is an associate professor of mental health services research at the University of East Anglia in the United Kingdom, and she's also head of research at the Norfolk and Suffolk NHS Foundation Trust. She's a rural health fellow with the NICHE Anchor Institute, an elected fellow at the Faculty of Remote, Rural, and Humanitarian Healthcare. She is chief investigator and co-investigator on numerous National Institute of Health Research and regional projects related to children and family health, community research engagement, and dementia care. I'm going to leave the rest of her explanation to her. And I just would like to please join me in welcoming Dr. Bonnie Teague. I'm just going to quickly.
I'd wait for the presentation before clapping if I were you.
Can you please assist? We're just going to pop her presentation up. Uh-oh, all right. Where is the Zoom? Oh, over here. Something would happen.
No, it's not. We can spend how we're looking at how to do Zoom because it's beyond me. There we go. Oh, nearly.
Check and see what's on your screen.
Where is it? It's towards the bottom.
Well, no, I need the actual presentation.
Yeah, screen one. There we go. Okay, can everyone see that? Okay. Online and in person. So thank you very, very much for inviting me to talk today. Before I get going, I really want to extend a very warm thank you to Leanna and Bree for marvellously organising today, and also to Erin, who originally invited me, who might be regretting it right now, and also to Caroline, who I don't think she's here, she's online maybe, and who's given me a very warm welcome and shown me around the lovely city and area of Prince George. And I just want to thank all of you as well for your interest in this area. So what I'll be talking about today, and I hope that this is going to be working, otherwise, nope, okay. Keep it going.
You might have actually clicked the arrow.
Yeah, I can't see a mouse on here. Sorry, no more.
It's probably on the other screen, so just pull it else off the order.
Yeah. There we go.
Oh, okay.
Okay, so what I'll be talking to you about today isn't about a particular research study, but you'll be hearing about several. It's the story of how we've developed a strategic programme of clinical research, which is embedded and drawn from health services in collaboration and joint collaboration with our patients, their families and our communities, along with academic partners and healthcare professionals as a big collaborative. I lead an embedded clinical research team, which is now quite a large one, and you'll see the story of where we've come from 8 years ago and where we've rapidly developed to now. Now, we specialise particularly in mental health and dementia research, but the story kind of goes beyond that in terms of what I'll be talking about today. So I'll be talking much more about the strategic development of a research programme from absolutely nothing, which is where we started from in a very short period of time. If you want to know where I'm from in the UK, I'm from this little kind of right ear on the right-hand side of the UK, so this bump here. And this is a rural part of the UK. Now, it only looks like we're very short distance from London, but all I'll say is it took me 3 days to get here, and the longest part of my journey was getting from there to Heathrow Airport. The rest of it's been great. But that shows you sort of, although geographically we're only about 3 hours from London, in terms of our infrastructure, our transport and everything, we are actually really quite isolated. So I'm going to give you, before we get going, a picture postcard tour of the area in which I live. That's always important to contextualise the area and the population in which we're working in order to then develop a programme of research. So I'm going to start by the beautiful picture postcard tourist brochure photo of area. So we have one city, which is called Norwich. It was a city in 1096. It's a very old place. It doesn't all look like this, but this is the kind of thing that you will be seeing if you ever wish to come to this part of the world. So beautiful old buildings, cobbled streets, all very charming. Outside of the city, the whole of the county looks like this. So farming, agricultural land, very rural, maybe the odd little house there, terrifyingly small roads in which everyone drives very fast. They're the roads I'm used to anyway. But there's a different side, as there always is, of the area. So we have immense pockets of neglect and deprivation of both the land and its people. So we have communities who are deeply underserved by health and social care services and across any kind of authority as well. We also, in recent years, do a fine line in coastal erosion, which is linked to climate change. So with climate change, we are seeing a rise in our sea levels. We're not on a rock bed. We are on an old glacier, which from hundreds of thousands of years ago, and this is now crumbling into the sea. And because we have a big coastline, we have a great proportion of our population who are now at risk in the next 10, 20, 50, 100 years of their communities and land literally falling into the sea. I'll be revisiting this towards the end of the talk as an example of a new programme of work that we are developing around the climate change impacts on health for our local population. So you'll see more delightful photos like that coming out. Now, in terms of our population as well, we are a rapidly growing population in this kind of rural part of the UK. That won't be unfamiliar to you because it's similar dynamics here. And we also have an increasing ethnic and cultural diversity within our region as well, including increasing numbers of refugees and asylum seekers who need quite substantial support from health services. But the thing that really marks the area out compared to any other part of the UK is the age of our population. So 1 in 3 of our population are over the age of 65. Now, the average 65-year-old has 5 health conditions which need support from the health system in some way. And this is physical health, it could be mental health. Altogether, that is an increasing proportion of our increasing population as we go on. And what does that mean for us as a healthcare system? Well, there's a financial aspect, because there's always a financial aspect to healthcare. And this is a graph which it's a couple of years old now, but it still holds true. And in fact, the swing of the graph is very similar in Canada, actually, when you look at this. So when you have a look at that kind of age of 65 plus, the healthcare expenditure which is needed for that population with multiple and increasing health conditions rises exponentially within our local healthcare system. And we are in a situation now, we have an increasing population, we have an increasingly older population who need to have this increased healthcare expenditure, but we have no more money. And so that's the challenge that we have. How can we deliver high quality healthcare to an older group of people in an environment where we have no money, more money, but we need to holistically meet their needs? So that's the kind of environment that I'm working in my rural area. So the government saw this on a challenge. This isn't anything new. We've been knowing that this dynamic would be happening for quite a long time. So about 20 years ago, just under 20 years ago, the government, recognising that this was on the horizon, thought that research would be health research would be the answer to some of these challenges of delivering high quality care, but in a cost-effective manner. And so it announced a new strategy called Best Research for Best Health. We're now on to Best Research for Best Health 2. It's like a Rocky movie, it keeps kind of coming back. But this is a 10-year strategy to develop an infrastructure of health research within the health service itself. It'll move research away from the unique domain of the university, but into now a collaboration where the health service will be driving its own research programs. It also intended to democratize research, and by that I mean move research away from the traditional areas of London, Cambridge and Oxford, which all of you will have heard of here. You may not have heard of Norwich, but there's still a reason for that. We still have some work to go. But the idea was to try and share research across the whole of the country and across different regions, so that everybody in the UK would have an opportunity to take part in high quality, world-class research. So to do this, they formed the National Institute of Health Research, years after the Canadian Institute of Health Research, but we like to copy. And this is what the NIHR looks like. So they had 4 prongs of development for the health infrastructure in the UK. So I'll start on the right-hand side. For the first time, they started to actually commission health research. And this was applied health research, where the outcome from the projects would be able to be implemented or impact health practice within 3 to 5 years, rather than the 17-year average we currently face between doing a research project and having any kind of impact into practice. They also developed a faculty. So this was for clinical academics and healthcare professionals to grow their research careers in the health system, so they could continue practicing as clinicians, but also be world-class researchers. They also developed an infrastructure of a clinical research network, which was effectively setting up clinical researchers within every single hospital in the UK. So every hospital got a little bit of money, not millions, unless you're a big hospital, but to set up some research specialist nurses primarily to help deliver this national portfolio of work. And then finally, they massively overhauled the ethics and governance system. So if you want to do research in the UK now, you only need one single approval, regardless of how many hospitals you want to work in. So that has radically kind of overhauled how we do research in the UK in terms of being able to set up research quickly. So the way that this works, has been working for about 15 years in this way, is that anybody in the UK, regardless of where they are, or Canada, actually now, can have has a research project funded by whoever. That is picked up by the National Institute of Health Research, where the project is placed onto a national portfolio, quite literally a portfolio of research, which is then shared across every hospital or organisation in the UK. So our local network is the East of England, and then that comes through to me to say, hey, do you want to contribute to this study? We need 700 people, could you do 20? And I will look at the study and go, yeah or no, depending on whether we're able to deliver that study or not. And this has worked very well, this particular system. We've now had over 1 million people a year in the UK who take part in health research. And during COVID, when we were absolutely spammed with vaccination studies and health studies, that doubled to over 2 million people. So it's worked really well. And we have had some successes. So just from our local hospital, this is probably the biggest, most impactful study we've been involved in, which was looking at how we can support older people who suddenly develop psychosis. Small part of the population, but it's a devastating impact on their health outcomes. And we had no prescribing guidelines and no care pathways for this group of people. So we contributed to this national study. It was led by London, but we contributed our few little people from Norfolk. And we found that low-dose antipsychotics prescribed for this population radically transformed their life in a really positive way with few side effects. So those are the kinds of projects that come through on a national portfolio. But realistically, in our little rural hospital, which is quite separate from this whole system, what impact did this really have on us? It was mixed. So yes, we had advantages in terms of the overhaul of the ethics approval system. So our average to set up a study went down from 9 months to 35 days, that we could set up and run a research trial and get approvals in that time. We do have a small group, 4 or 5 nurses who are now clinical research specialists, also clinicians in their own right, but they go out and support the recruitment and data collection for these national studies across our patch. But that was kind of where the advantages stopped for us. So we weren't able to create any meaningful opportunities to obtain our own funding on the work that we wanted to be doing. And we were certainly not able to develop any of our clinicians to get to a point of being able to join this national faculty, because although we were working on behalf of other studies, we weren't really seen as a credible organisation in our own right to attract funding. Because effectively research is all about one group of strangers trying to convince another group of strangers to give you money. I mean, that's fundamentally what research funding is all about. And we were a group of strangers that no one knew. So this whole national system, which works very well on kind of a national level, for us in our little organisation, in our part of the world, only had a partial success. And there are reasons for this. So we did an exploratory evaluation a few years ago to find out what people thought of research within a hospital. And effectively what we found is that nobody in our system, whether it's the clinicians, our patients, their families, or even the research practitioners, felt any ownership of this work. We weren't involved in the development of it. We weren't involved in how it was set up. We were acting as a service for people, and we had no say in what the priorities were in that research. This second point about impact particularly was something I felt, because whenever I had to talk to directors or leaders of our health system, they would always ask, well, what impact, what benefit is research having on us? And I couldn't answer the question because it didn't actually have any benefit that I could talk about meaningfully, apart from 1 or 2 small victories. But as a whole initiative, it just didn't have that resonance with our local system. And also, just on the kind of rural front, a lot of these studies had still come from London and Oxford and Cambridge and were set up for an urban setting, which was very well serviced by support services, scanning, phlebotomy, you know, all of those kinds of things, which you need to run a survey, a big complex trial, which we simply didn't have. So it meant that our patients were having to travel hours and hours and hours to go to an urban centre to be seen, and quite often didn't get compensation for that. So we had this kind of disconnect, kind of cultural disconnect, and generally the research that we were doing on the national level wasn't hugely impactful on our hospital. We were doing it for sure, but it didn't have great meaning or change. And we were frustrated by this. So in 2016, we developed what was quoted ridiculously ambitious hospital research strategy, in which our emphasis was all about growing our own national research portfolio. So things which were in the priorities of our hospital, our communities, our patients, our families, and obtaining national funding for that. We also wanted to develop the research skills of our healthcare professionals in the system and work with our university partners as equals in that relationship. And particularly important to us, we wanted to meaningfully engage our patients or service users and our carers, particularly people who weren't being heard in the system right now, and have them as equal co-researchers or advisors within our programme of work. So that was built in right from the beginning. And then we also wanted to obviously get some more money in to the hospital, that always works well, and be financially self-sustaining or sustainable within 5 years. Now, we were told that this was not going to work. I just kind of thought, well, we'll get further from nothing, which is where we were starting. We had no homegrown research whatsoever. So I thought, even if we get one thing going, it's better than zero. Now, we've actually achieved all of this. The only thing we didn't quite achieve was this last one of being sustainable within 5 years. It took 6, and then we're there. So we've done all this, which is great. And our very first challenge was, well, how do we start? Because we're coming from nothing with nobody, and we don't know what we're doing. Please be honest about that. And we looked around other hospitals who had tried to develop something. And what they had all done collectively was try to buy out the time of physicians to do research. Physicians were seen as the holders of research knowledge because of their educational background. And what we kind of observed realistically is that physicians don't actually really have those research skills which are needed for health research, first of all. Not everybody, a lot of them, but also simply don't have the time. They're firefighting the whole time. And what we found constantly was that clinical priorities always took over the research priorities. And within the kind of wider system beyond us, millions of pounds are being dedicated to buying out physicians' time, which have led to nothing. And that's not, I'm not blaming the physicians for that, that's a system problem. So we decided to do it differently. And we instead moved away from physicians into the workforce which works most hand in hand with our service users and families, who are very well educated and are very good at telling us, what is the problem with the health system and some potential solutions. And that was our nurses and psychologists. So that was where we started our journey, was by advertising a very small scale evaluation fellowship for 1 day a week, primarily aimed at nurses and psychologists. Physicians could apply, but they didn't. And we started strategically because we advertised it to say we want someone to work in child and young people, adult, working age adult, and older people and dementia. And the reason we did that is because that fell down the clinical lines and the way that our hospital was organised in terms of its service delivery. So we wanted people to come from those services and across the whole age span. And these three lovelies came forward. So we have Jeannie here, who is a nurse working in dementia services. We have Tim, who's a child and youth psychologist. And we have Karina, who's in working age adult psychologist. And they came forward with projects that they had born out of their own practice and observations. And that was quite literally where we started, a year fellowship for 1 day a week. Now, what I'm going to do now is jump forward to where we are now, and then I'll go back to talk about how we've done that. So that was where we started, blank slate. What we now have are all these programs of work which are fully sustainable and have attracted external funding across these three lines. So you'll see the three lines, child and youth, adult and older people, and that has now been joined by health inequalities and inclusion as a cross-cutting theme underneath all the clinical services, but has now taken on a life of its own because it's kind of its own research area. And so these are our areas of specialty. These aren't all the grants we've had in, but these are some of the grants that we've had in from national funders. So we have a lot of our funding from the National Institute of Health Research itself, but also from some global funders, so from professional funders, so nursing charities as well, and also some regional funders as well. This isn't everything. These are just some of the big hitters that we've had. So what's happened in that time is we've gone from quite literally the bottom of every hospital in the UK in terms of our research portfolio up to the top 20% of all hospitals in the UK. And one thing that people hate about us is this statistic here, which is that generally in the UK, between 10 and 20% of research applications for funding are successful, whereas in our world, 73% of our applications are successful. And I'll talk to you in the rest of the session about how we do that. So why are our ideas usually funded more often than not? And that's because of the approach that we take, which I'll talk to you more about. We've gone from 0 clinicians to over 100 clinicians who are now actively and meaningfully involved in research, either as co-applicants or co-investigators. We are part of clinical inspections at the hospital as well. So research comes under the well-led criteria and leadership of the hospital. So that always looks positive. And just in the last couple of years, we've won awards, hooray. So we won Outstanding Population Health for a particular project we were doing about implementing digital therapies into child anxiety, to support child anxiety. So that's where we've got to right now, and we have a lot more plans coming up as well. So I'm going to go kind of return back now to how did we do that? So how have we got to this point of nothing through to what has become a very vibrant embedded research culture within the hospital, in which a lot of people are now involved across the board. And these are the kind of 4 main points I'm going to be talking about. So one is about how we've engaged our healthcare professionals. One is about how we've engaged healthcare students in our partner organisations, our universities. One is how we've engaged our patients and our communities. And one is about the methodological approaches that we have changed whilst we've been doing this programme and the learning that we have been getting from the research that we've been doing. So let me start with the professionals here. And one of the very first things that we did was develop a research competency and skill development framework. And this was for all clinicians in the hospital, all professionals. It didn't matter which service, what level, what qualification, what discipline people were working in. This applied to everybody. And so the first level was purely know research is happening, know how to talk to your patients and their families about research, and know how to potentially refer somebody who's interested into a research study. And that worked really well because it didn't mean that healthcare professionals had to know all about the protocols and all the different studies and everything. They just had to learn the general principle behind offering research to people. The second level is where you did become kind of au fait with protocols. So becoming a co-investigator on one of the research projects, whether it's a national project, a little project, evaluation, didn't matter. But you learned how to actually engage and deliver in research studies. Then once you were kind of bored with that, you moved to developing your own project because everybody's got ideas. And that's something that we learned very quickly. So we then encourage and support people to develop a small scale project. Now they might go for funding, it might not, but we just want people to learn the process of writing, of owning and doing and publishing their own small scale project. And then once they've done that, we encourage people to obtain funding for further clinical academic career development. Now, what you'll see is that there are some lines here in italics, and these are the training courses that we have developed in-house and which we offer to everybody within our healthcare organisation. And so this is a very goal-oriented process. And I mean, we just set it up as a way of trying to embed research into somebody's kind of working life. And it worked incredibly well. And people would come into us and say, I've made level 1 now, what do I do for level 2? And like people were really motivated by the system, which I'll be honest, kind of surprised me. I was hoping that we might get a few people up here, but actually we've had over 600 people who've met the level 1 criteria. And we've now got over 100 at level 2, around 30 and around about 20 who've now met this level 4 criteria from nothing. And I'll give you a couple of examples of how this has worked. So this is Asta, the lovely Asta, and he was a pharmacist. I'll be honest, I hadn't really thought about pharmacy in all of this, but because this was open to everybody, he came forward. So he started out, he's a mental health pharmacist, and he started to promote research by a database that he managed. He then became a co-investigator on a national study, which was looking at medication adherence, and he fell in love with that area. It just talked to him. So he then, just off his own bat, which we helped with, did 2 systematic reviews which were published. He then became the first national mental health pharmacist to obtain PhD funding from the National Institute of Health Research. So he's now gone to Dr. Chakrabarty, where he's or just finished, and now he's just been awarded a postdoctoral fellowship, which he's now doing. So you can see this kind of progression. 8 years ago, he was a pharmacist working clinically. He's now obtained a PhD through this system, through the opportunities he's had, and is now a postdoctoral fellowship, seeking to become an independent investigator as a clinical academic in practice. A second example is Louise, and she's a mental health nurse, particularly for older people, but not dementia, but it's more the mental health side. And so she was working in clinical services and became involved in research. She actually joined us as a research nurse in the team. She obtained funding to do a master's in clinical research as well. She became a PI in a national study. She then developed a small scale study which is now being published, which was looking at dementia assessment tools. And now she's a chief investigator on a big program of work relating to menopause in the workplace, in our ageing workforce, and has now almost moved to a level 5 because she's now become a hospital nurse and research lead for us, which is a position she's created. We never had that before. And so she's the first person to have gone into that. Now, what does that mean? What does she do? Well, she works with our university people, our university courses to demystify research for student and aspiring nurses. What we found out from nurses is that they often didn't want to get involved in research because they associated it negatively. It was all about data, stats, spreadsheets, the things that nurses do not like at all. And so we've reframed that. Research is about patient care. It's about improving people's lives, improving access to care, experience of care, and outcomes of care. And as soon as we start using that language, nurses get on board. Absolutely fine. So what we're able to do now through Louise's work, and we work together on this, is we offer clinical research placements for nurses in their final year of training. And then they can be with us for up to 6 months, and they learn all about research in that time, and can understand how to embed it as a nurse in clinical practice as well. And we also teach on the courses as well. We also supervise nurses. So nurses in the UK need to do some kind of dissertation, research-based dissertation. And we make sure that these dissertations align with our research strategy in the hospital. So they are always in the areas of child and young people, adult, older people, or now health inequalities. And these are just 3 examples on the right-hand side here of where the nurses have led on projects, either as the first step into a new programme of work or to supplement existing programmes of work in different areas. We also do continued training. So newly qualified nurses who are aspiring to develop their careers, we also use research as a way of developing their skills clinically, but also their careers as well. And then we run a region-wide, we call it NREG, like an old car, but it's a nursing evaluation research group. That is where all the nurses come together to just discuss about new research which might be impacting their practice, or if they have ideas, we support their development of it, or critical appraisal of new papers, anything like that, just to build this culture. And that's been really helped by our lovely deputy chief nurse in the hospital. The very first time I met Dawn, she walked into my office and she went, "I hate research, hate it. Nurses don't do research." But now she's PI on 2 studies and has had multiple publications. We've brainwashed her in terms of the impact of research in a nurse's life. And so she's now a huge advocate for what we do. And that's really important to have those people who are championing, particularly for nurses, but championing research as part of our clinical practice in everyday life. So the third strand are the most important people, who are our patients. And we really wanted to make sure that we were meaningfully involving people right from the beginning, not just in individual studies, but in our whole programme of work. So we first of all undertook a research prioritisation exercise, and this was again in our populations of child and young people, adult, older people, but also underserved communities, these pockets of underserved communities who are not being heard. And we undertook separate research prioritisation exercises with them. We can make sure that their needs were being heard and met in that time. And here's a publication that came out of that, which is always helpful because we can cite it in grant applications to show that we've done that work. We make sure that all of our research materials, including our kind of generic material, promotional materials, are co-designed. So this is our children's pack. We worked with a group of children from age 8 to 15 to develop these research activity booklets with their art, with postcards and everything. And this is now sent out to all participants. And we have that for all our 3 streams as well. We make sure that all of our studies and all of our management awards have representation from people with lived experience, which I'll talk to you about that term in a moment. We also have on all of our studies that patient representatives are co-applicants or lead applicants now, and are definitely co-authors on pretty much all the publications that we have. We have around 40 to 50 publications a year, and if you look at our list, you'll see, well, you won't know by name, but the vast majority of our publications have a patient author or more than one on there as well. And this is one example of a paper on the right-hand side, which was actually led by one of our patients. And she was really interested to learn about the impact that COVID-19 lockdown was having on people living with a severe mental illness. So we supported her to do a small-scale project, which she published. Just in the last couple of years, though, we've broken through the barrier of having patient-led or user-led research. So this is where patients are now actually chief investigators of national studies, who are supported or co-supported by us. And I'll give you an example of this in a little while. And this is just an example of what our prioritisation discussions have been looking like. So we start by asking, what are the grand challenges for you? Well, the wicked problems is the other way of looking at it, about your healthcare, from your experience or from the experience of your family members, or your profession or your practice. What do you feel like the big problems that we could address by research? What do we need to learn about these problems to help resolve the problems? We ask that. We then ask, what can we actually do in our area? Because we can't do large-scale genetic studies. We haven't got a lab on the side where we can do analysis of things. But there's a lot we can do with our communities and with our systems. And then how can we, and I think it's like a really crucial question, how do we design research in a way that people actually want to take part in it? So rather than doing a topic that people want, but we deliver it in a way people don't want, which makes it difficult for them to take part, how can we actually build in that knowledge into our research design in a way that makes it easy for people to take part and where people are really wanting to make that effort and that time to take part? So we ask about the kind of design of the projects in this, as well as the area as well. So just the kind of the fourth prong of what we do is our methodological approach. So when we started, we did the thing that you were always told to do, randomized controlled trials. It's the gold standard, yay. And that's what we started. And we ended up, the first few years, having a litany of things that did not work. And either because the intervention we were trying wasn't effective in the context of our services, or if it did work, it wasn't able to be implemented effectively within our services. And so we were kind of back to this thing of, well, now we're doing work, but it's still having no impact on us whatsoever, apart from we're learning what not to do. So we had a whole bunch of papers which basically was saying, this didn't work. This is no better than treatment as usual. Now that's helpful. It saves money rather than investing in an expensive thing that doesn't work. But it still didn't change anything about our practice. So we've now moved away from randomized controlled trials. We can do them, and we sometimes do. But the vast majority of our work now is much more context specific, where we're learning much more about our healthcare system at the same time as doing research. So research is no longer something that is done kind of on the side of clinical practice. It is done at the same time. It is embedded into our systems as we are practicing. So we do a lot of evidence-based co-design, which is developing our interventions with our communities. So we know that there are things that are feasible and are wanted and will be useful. We undertake a lot of realist inquiries where we've changed the question from does this work into who does it work for, how does it work, and in what way does it work, or what way doesn't it work when it doesn't work. And we learn a lot more about our health system by changing that question and into a more kind of qualitative inquiry, which we're questioning our system as much as whatever the intervention or program change is. And adding to that, we now couple that quite often with a systems engineering approach. Sorry, I'm going a bit mad back here with the systems engineering approach, which we lay out and plan out exactly what our health system is, all the drivers of care or the inhibitors of care. So if we're trying to change something in the middle of that, we are able to see the consequences, unintended consequences, and the good outcomes that might happen. I'll give you an example of what that looks like in a minute. You nearly had it then because I was in the wrong direction. And then the other thing that we do is also make sure that we are using implementation science approaches within our work as well. So at the end of a study, we don't say this works, this has a p-value of 0.01, aren't we good? What the actual outcome is this feasible to be implemented into our context of our rural practice in our messy, complex health system now. And that's the kind of chief outcome of all of our work that we do. And one way that we do that, and one way that we examine our system within that, you have had a preview of this quickly, is by joining up with other healthcare systems and organisations who are very different to us. So we are off here on the right-hand side in the green, this little kind of rural area on the right-hand side of the UK, but we work with everyone in red. We're obviously need to do more in Ireland, by looks in Wales, but we do a lot of work where we are comparing our research and systems and outcomes with those in the city London, for example, or up in the north of England, which has very different demographic and social demographic profiles to our part of the world. And we collate all that information and we're comparing and contrasting the research that we do across these very different systems. So we actually learn a lot more about our system through that, by comparing it with contrasting systems as well. So by doing that, what it means is, research is now embedded into our whole system. It's not seen as an additional burden of time on top of everything else. But our outcomes have shifted. Our outcomes are about what we learn and what we learn together along with our patients and families and communities, rather than asking, does something work or not? It's about what we learn as a whole system and about ourselves. And we found that this has been a really effective way to try and inform policies and commissioning, because actually this learning is wider learning about who we are as a health organisation, what we're able to achieve and what change we're able to achieve is incredibly helpful for health leaders to learn how to support what services to commission, what teams to commission, what treatments to commission, because they have a much greater understanding of our system and the drivers and facilitators or barriers to implementing change and care within that. And from a research funder perspective, it's a safe bet because you have really good outcomes, learning points coming out of it, not investing £3 million in an intervention that doesn't work. You have something much more meaningful coming out from that. So I'll give you a couple of examples. You will see this very quickly, we're going in the wrong direction. So Discovery is a project which was looking at, it still is actually still going on, which is looking at how we can try and develop post-diagnostic support for people with dementia. Now, the UK is one of the top, and you'll always see this on the headline, the UK is one of the top, has one of the top diagnostic rates in the world. Great, but what we do is we diagnose people, give them a leaflet, and off you go. We don't offer them any kind of systematic, meaningful support of how to live with what can be a devastating diagnosis and a lifelong diagnosis or life-limiting diagnosis in some cases. So how can we best support people to to design a system and design a post-diagnostic support mechanism that works for them? And so we are co-developing it's a guidance for how to develop post-diagnostic support within the healthcare system, which is being co-led by this lovely group of people here who live with dementia, some of whom have quite advanced dementia. And so one of our key learning points is how can we engage people with advanced dementia in being able to set research priorities and develop their own healthcare, despite all the kind of communication limitations around that. And within this, we've used evidence-based co-design with people with advanced dementia to design the post-diagnostic support that they want. And we also use realist inquiries where we are asking, okay, what does this post-diagnostic support look like in this context? How could it work? What would the benefits of that be? So to give an example of what one tiny little aspect looks like, one thing that everyone said to us is if you're expecting us to come to a course or come together in a room for a group session, we want a co-facilitator who themselves has dementia. So, okay, great. But why is that important for people? So we unpicked that through the work that we do. So what we found in that work is that a peer tutor, so somebody who's living with dementia, who's part of this course, shares their own experiences of living positively with dementia. It's no longer a devastating disease. It is something that people can live with and thrive. And then that resonates with attendees who see both the positives and the challenges of living with dementia, and that they feel that there's more connection, more hope, and more shared learning between them by having that person in the room. And so that's one of 50 examples of the work in which we've really broken down the value of these certain components of this intervention, whether it's a group session or a treatment session or guidance, whatever this is going to turn into, because we understand what best practice is, but we understand why as well. So that's discovery. A second example is this, and this is our first national study, which was led by Sarah Hughes, and this is Sarah here. So Sarah had a lived experience of being in inpatient mental health, being on an inpatient mental health ward, and she came to us saying the discharge process was the most harmful part of her whole care. Now, I've highlighted this because involuntary admissions is a big thing in BC right now. I've seen it a lot on the news in the time that I've been here. But one thing I haven't seen in that conversation that I've been hearing a lot of is what happens when people are getting ready to be discharged from that health system, and what things do we need to put into place to protect people's well-being in that system as well. So it's something, if you're involved in that involuntary conversation, I would just encourage you to think about the end point. The admission is one thing, but the discharge process can be incredibly harmful to a point where people just literally walk out one door and come back round into the other. And we were seeing that a lot in the UK. So we did first of all, we did a survey to find out if Sarah's experience, I'm off again. Sarah's experience was replicated across the country, and yes, we did. So people were telling us that they had been on an inpatient ward for 6 months and they were given 10 minutes to get their things and out the door because they needed the bed. And a lot of people, almost everybody, had not been involved meaningfully in their discharge planning at all. They were just not involved. They were not empowered. They were not informed even about what should happen to them afterwards. And a lot of people had lost their homes, because that's what happens when you're in an inpatient ward. You can't maintain a home at the same time. Where do you go? You go straight back into the mental health system. And that's what kept happening. So what we've been doing on Minds is developing a new discharge process. It's not really an intervention. It's about how we can best support people, including the healthcare professionals, to support those on a much longer trajectory to their discharge planning from inpatient wards. And we've used this systems engineering approach to map out what this discharge planning looks like. And it looks like this. It's a mess. It is hugely complex. I'm not expecting you to be able to look at this. But effectively, where we're coming from with Minds is if we're going to try and change something, let's just say randomly that's thing here, and maybe put in some kind of new process, new guidance, new whatever, what impact is that going to be having on this whole interdependent system? It's going to be huge, and there's going to be good consequences come out of it, but there's also going to be unintended consequences or pressures somewhere else in this system. So being able to map all this out has been incredibly helpful to understand what might happen if we wanted to actually meaningfully change practice. And in a way that has involved everybody in that process. So our patients, their families, our communities, our professionals, our commissioners, everybody have all contributed to developing this engineering process around discharge as well. So that's got about 6 months left to run. So when we've come out with that, I'll share the outcome from that as well. So I just wanted to quickly, as I'm starting to wrap up, talk about some of the things we got wrong and some of the challenges that we've been facing as well. So the very first thing was about the lived experience side. And this is why I kind of said I will talk to you about what that means in a minute. So when we started this, in great naivety, but with good faith, I just want to put that in there, we set up a catch-all group of lived experience advisors who we would go to for all our work. And we would ask them to advise and collaborate and be researchers on all of our projects that hadn't actually even been written yet. That was a disaster on so many levels. It did not work at all. It was convenient for us. And that was the kind of way that we were looking at that. It's good for us. We have a group of people, we can use them. And that's a really rubbish mindset to be going into with research. And so what ended up happening, it lasted 18 months with a lot of hurt feelings at the end of it. Because the term lived experience doesn't actually mean anything when you've just got a group of random people in a room. So all we were getting back when we were sending these projects over to them was, well, I can't comment on this. I don't have a lived experience of that particular condition or that particular service. I can't do anything to help you, but you've missed out a full stop at the end of that sentence. That was the kind of level of engagement we were having. It was not meaningful. And actually, it was a way that made people feel more disempowered because they would come back going, I'm really sorry, I can't help you with this. And so it was actually creating quite a bit of harm in those people who wanted to help but couldn't because we had set up that system. We also really didn't account for the fact that, of course, people were living with multiple health conditions at the same time, and we weren't taking care of them in that space at all. So people were coming with multiple complex mental health conditions particularly, and we were like, oh, but we're research. We don't do that clinical stuff. Go over there. And that isn't helpful at all. So we weren't allowing people to feel safe when they weren't feeling very well or didn't have to engage at the time that they felt that they couldn't. And we weren't supporting them at all. And that led to some very sort of negative, and quite right from their perspective, but some very negative feedback and experiences from this group because we were using people. We weren't taking care of them as individuals or as co-researchers in the way that you would a colleague. So we did everything wrong there. It was designed to reduce tokenism of a tick box of, yes, we engage with patients, but it actually fed into that much more than we hoped to. So now what we do is every single study has a dynamic group of people who have that specific lived experience. And they control exactly what the involvement that they have, how they feedback. Effectively, what we do is we co-design the co-production with them. And they are fully in control of their involvement from the beginning. The other big challenge is our workforce. So the way that we've built this program up is all relational. It's all about individuals, their relationships, their networks, their expertise. And we are working in an environment which is aging as well. We have an aging population, the workforce is aging, funnily enough. And what we found is a lot of the people we work with in our greater networks and within our team now are now starting to leave. And that's nothing to do with our work, it's just life. You can see that this is the UK. Look, COVID happened and a lot of people left. the workforce, because everyone reflected on their lives, who didn't at that time. And so a lot of our collaborators in academia and healthcare left, and we lost that expertise, we lost that friend to our programme in that time. We also have an increasing number of people who are retiring in the next 5 or 10 years, including members of my team. So people you've seen, whose faces you've seen in this presentation, are going to be retiring soon. And again, we're losing those people from the system. Now, what is of concern to us is we're not seeing a new generation necessarily coming through. So nursing admissions in the UK have dropped by 21% in the last year because of financial issues and because of politics and issues with course delivery and all kinds of lovely stuff like that. So we're a little worried about who our sustainability, yes, we have financial sustainability, do we have a workforce sustainability? And that's our new challenge as we enter the new phase of our work, which is how can we start to build this workforce sustainability in a very, very tight, under-resourced health service. And that won't be unfamiliar to any of you, but that's the environment that you're working in as well. So just for the last couple of minutes, I'm just going to finish off, because I'll be shot if not, by talking to you about the latest programme of work that we're doing. So I have to give a plug to the people who funded me to be here, so you can blame them. So this is the Niche Anchor Institute, and it's the very first institute that has been set up to investigate rural and coastal health inequalities in the UK. So as I've been walking around here on the campus, and it's beautiful, I've seen a lot about rural health here, a lot of rural health initiatives and programmes in it, We don't have that in the UK, although a lot of the country is rural, and a lot of people live rural. And in my part of the world, 63% of my population lives in a rural area. We don't recognise it as a thing in healthcare delivery in the UK. And we're just starting to get to grips with, oh, maybe people who live out in the country are a bit different to those who live in inner city London. So Niche has been set up to develop an evidence base around what rural health inequalities mean in the UK. And there's already been some really interesting work come out. So we've already seen that there are incredible inequalities in non-communicable health, non-communicable health conditions, communicable health, mental health, substance misuse, and increasingly suicide rates are hugely higher in rural areas than they are in urban areas. There's aspects of economic differences, but that isn't the whole story in the UK. So the Niche Institute has funded me to start building some of this evidence base in the UK context, and compare it with other lovely places like British Columbia as well. So one of the main projects I'm working on is called Coracle, which is a kind of little boat, Norfolk boat. And this is for the first time asking children who have complex health conditions what their experiences of rural healthcare is. It's the first time it's ever been done, because we tend to avoid children and go straight to their parents as a proxy, but the parents have very different opinions to their children. So I'm really keen to, I'm talking to the parents for sure, but I'm also talking to the children who are living with multiple health conditions, age 5, age 7, who have very strong views about the care that they've received, good or bad, but have never been asked about it. And I'm building a picture from a children's perspective of what rural healthcare looks like. And what I found, which I wasn't expecting going in, is around half of my participants so far don't communicate verbally because of their health conditions. So we've had to try and be creative in how I'm collecting data and their views. And this is just one little picture here. And this was drawn by a 7-year-old and who communicated through her art, and beautiful bus that she's done. And this was in response to what is, I said it better than this, but what is stopping you from being as healthy as you can be? And she drew the bus. And what she meant by that is there's no transport where she lives in a little village. So she can't go see her friends, and she can't go to a swimming pool, and she can't get out and be social at all. She's trapped in her house with her health conditions. And that was everything that she meant by that little bus right there. So that's the project I'm currently undertaking. And so, but when you start asking a question about a new thing, what you end up with loads more questions which come out, because everyone's like, oh, that's interesting. Well, have you thought about this? So I was funded to do Coracle, that one project. And in the last 12 months, this has erupted from this work. By starting to ask about rural health in a new context, everybody's now come on board. And it's like, well, have you thought about farming mental health? Because that's a really big issue, which it is. So let's do a study about that. How about healthcare professionals? They're really uncertain about how to work with rural and agricultural communities. Okay, let's do a study about. So it started to build this huge program of work, which can only have been developed in an environment where we have a really fertile research culture, which has been able to be turned around within 12 months and developing this massive program of work. So I'm now juggling a lot of balls in the air with this one project by coordinating all of this. So just to give one example of a new piece of work, so I did promise this at the beginning. So Ripple, as we've been asking about rural and coastal health, we've now crashed straight into climate change and the impacts of climate change on the psychological well-being of our communities in Norfolk. So I'll give you an example of what we're talking about in terms of our challenge. So this is a place called Haysborough in Norfolk. It's not spelt how it sounds at all. And this is a picture from 1995. You can see there's a few houses on the coastline here, nice roads and stuff like that. 14 years later, look at that as the index house. All of this had gone. All those houses, people living in them, the people were safe, by the way, they got out in time. But all of these houses were gone, the roads were gone, all of this had gone. Now, because I went up there a few weeks ago, the only house that's left is that one. So all of that is now gone. So how do we help those people? What is their psychological, what is their mental health when you are living in a house like this, right on the edge, which you can't sell because who's going to buy it? We know what's going to be happening. How do you prepare for that? How do you prepare for the next 24 hours you might have to leave your life and your home and everything in it? How do you protect yourself and your family in that? It's kind of similar to the wildfires in this part of the world, but it's a bit slightly different as well, because we know it's going to be coming. It might not be tomorrow, it might be 10 years or 50 years, but it's something that will be happening, particularly to these group of people. And so we've just finished off a project which is talking to these communities about their mental health in terms of what they're facing in the future and their level of preparedness, which it turns out isn't very high. They haven't really thought about this. They all know, like, Bob's caravan went over the edge, but they don't associate it with themselves, which is really interesting. So that's another piece of work that we're doing. So just to finish off, what we're doing next, because you can tell we don't sit on our laurels very much. We're about to develop a new 5-year strategy to do even more stuff. But we're planning to develop a formal centre for this kind of health research going forward, particularly around mental health and dementia and health inequality and rural health, hopefully. We're planning to increase our facilities. I've just actually had Marcus say that we've got new facilities, which is great. And we're going to be offering increased placements and opportunities for more clinicians to be part of the programme of work that we do, including international placements, which we have done. So if anyone's interested, happy to collaborate. And we will be setting up these global research collaboration groups as well in some of our areas of interest, which you are all very welcome if you're interested to join as well. And that'll be from 2025 onwards, which isn't that far away now, is it? And that is it from me. So that is my email address if anybody would like to get in contact. It's been lovely talking to you all. So thank you very much. And thank you on time as well, Ish.
Thank you so much, Bonnie. That was fantastic. Would anybody have any questions for Bonnie? Oh.
I knew you would.
Couple of first questions. In the first slides about the certification levels from level 1 to 4, and then you have to have a fifth one.
Yeah.
Is it a kind of formal program for participants? You know, like I'm level 1, and I'll get a title, and then level 2, et cetera, et cetera, et cetera.
Yeah.
So they see themselves sort of a cohort or a group that are advancing.
Yeah. So everything that we have in those levels are labeled as those levels. We give people certificates or letters to state exactly what they've achieved in that time. And so they use, I should have said that, apologies, which they can use for their continued professional development or in their appraisals. They know exactly what level that they're on. And actually a lot of them have used it for career advancement clinically as well, which has been really lovely actually to see that people have now become like nurse consultants or whatever because they're on level 3. And so they use that, and we give them the evidence trail behind that as well. They also get the separate certificates for the training. So they all get certificates for each course that they do, which contributes to their continued professional development time. But they also do get a certificate to say you are at level, you've achieved level 1, you've achieved level 2, and this is what you've done.
This leads to my second question. How do you, like, you've been providing examples of the whole region where you work with, but how do you invite these clinicians to go into this pathway? And for people who might not be joining this group, not to see like, oh, this is a subunit or this is a dedicated group, etc. How were you able to permeate the culture, even though clinicians might not be joining this specific pathway?
So we do a lot of promotional activity across all clinical teams. First of all, where we're talking about the system, and we're talking about all the different groups that people are able to join and contribute to. We use a lot of internal comms around the hospital to say, you know, this is our system. Hey, we've got level 1 training, or we've got, you know, so we try to make it as open as possible. We don't want someone's professional job to be a barrier to anything. So although I've talked about a nursing group and we have a psychology group, you know, we try to have a route for every single person to be part of, so that nobody feels excluded. And we've never heard of, well, I don't feel like I belong. We've never heard that, which I think is not, you know, it's really nice that people feel that they can, anyone can be part of it. So we have administrators who are part of it. We've got an accountant. No, it's scary. We have an accountant who is not our accountant, who's part of the research group as well. And it's just something that they're really, you know, they're interested in, and they're level 2 actually. So yeah, that's it. So that's kind of it. It's a very, we make sure it's very open.
I think you can talk a little bit around the tensions for who holds the funding.
Is that sort of between hospital and university by any chance? Yes. There are some tensions there, but so what happens in the UK with funding is there are some programs which can only be led by hospitals. There are some programs which can only be led by universities. And there are some programs where we have a big bun fight as to who's going to be leading on it. Now, it took a number of years to come up with a gentleman's agreement with the university, because everybody wants to be the lead organisation on something. Now, for us, it's actually more important in the university, because when we get lead on one of the projects, we also obtain some additional infrastructure funding, which the universities don't have. So we are really keen. Now, the gentleman's agreement we've come up with is if we are introducing the idea and we've developed it, we lead on it. And it kind of doesn't matter whether we've got 5 people from a single university who's part of it. If it's a hospital idea and it's recognised as such, and it's the funding that we can go for, we will go for it. And they are our partners. Now, they still get the ref stuff in terms of publication and income for them. So they still get a great advantage, but we're the lead organisation. Equally, if it's an academic introducing something to us, we'll be like, well, you lead on it. Because we will be your partner, we will have a portion of that funding, we will be seen as a partner, but we're not necessarily a lead. So what I didn't mention here is all our partner collaborations, which would have gone on for another kind of 10 slides, because we are very open, and we do work with about 25 different universities around UK and beyond now. So yeah, so that's how we do it. So it is an agreement it was difficult, I won't deny. But that's kind of how we've proposed it, and the university have agreed to that.
Can I just ask a follow-up?
Of course.
Is there any tension, because I just immediately thought of our context.
I felt you were just out for meeting.
Is there further tension then about partnering with your local universities versus the others elsewhere?
No.
No.
So because we are quite independent, and we tell everybody up front that we are independent, we work who we feel are best to do the job we're asking. In a way, the university have got no right to say we're not allowed to do that. We can fire them. So the power has shifted a lot. Our local university does get a little bit, this is being recorded, isn't it? Our university has concerns about the fact that we are doing a lot better than they are. So in fact, I'll say this, and I'll say it bluntly, our research income for mental health and dementia is higher than the university now. And they're concerned about that, but we tell them where they're going wrong, and say that we're happy to work with them. But also, we are working with 25 other universities, 40 other hospitals or whatever we're doing in the programme. And we are only contracting them for one part of that job. And as long as they understand their place in that, it's fine. They can't dictate what we're doing. So that's kind of, it has changed over time, that conversation, as they've realised that we're more successful than they are. So that's how it works. So it's a bit bullshit, but you know.
I have a question online.
Yeah.
Have you seen an evolving alignment with the health services quality improvement teams? One of your slides looked a lot like a spaghetti diagram often used in quality improvement.
Yeah, so quality improvement, we work very closely with that team because it's all about, fundamentally, it's all about quality of services. We input a lot into their work. We advise on the evaluation around QI projects, particularly. And sometimes the QI projects can grow into a much bigger piece of work, at which point they come to us. So we do, I wouldn't say align, as in we're not doing the same thing at all. We're doing things on a much bigger, complex, messier scale, I think, on a national level, whereas QI tends to be discrete, small scale change in a short term. But we do work together collaboratively and very closely to input in on each other's work quite a bit. So the spider diagram, which was a system engineering thing, I think, is born from the driver diagrams that you see in QI. So yeah, but we are, you know, we're neighbours more than what you think. Yeah.
Thank you again.
Thank you.
I should have mentioned there was 17 people online.